All right, we got a couple more minutes. So minor review slides. So these are hopefully the flavors of inflammation we learned last week. I don't think that's symptoms. So in general, what I noticed about this list is these are all very juicy things. These are all very juicy inflammations, right? Edema, fibrin, necrosis is juicy, mucus, juicy, pus, juicy. Anybody ever seen an angry mast cell tumor? Yeah, it's all swollen and juicy. I'll post this later. Chronic inflammation. I see things that are absolutely not juicy. Lymphocytes, not juicy. Granulomatous, TB, think of a TB granuloma, not juicy. Fibrous, that's scar tissue, not juicy. Granulation tissue is actually a little bit juicy because we're making baby blood vessels, and baby blood vessels juicy. All right, so lymphocytes and inflammation. These are probably one of the more frustrating inflammatory types for you guys because they don't have any classic gross appearance. So I can't look at a picture or a body or a tissue and say, oh, that looks like lymphocytic inflammation, because it doesn't really look like anything. These guys are gonna come in 24 to 48 hours, so a little later and overlapping with the macrophage time period. Remember, they can leave the site of inflammation and return to circulation. That's how we get memory cells storage. But they're also going to proliferate at the site of inflammation. So unlike neutrophils, same. In inflammatory lesions, they're often going to be around the periphery. So remember those T helper cells kind of sitting on the sidelines and directing the guy on the roof. They're going to be kind of out of the main action, but they're going to be close nearby and keeping an eye on things. So this is a granuloma. All these pink cells in the middle are those epithelioid macrophages, very active. And these little blue dots all surrounding the macrophages are sites that are stimulating and directing what's going on here. In the brain, we often see them lining up around vessels and forming what's called the perivascular cuff. Their other purpose in these lesions is not just to participate in inflammation, but after we've resolved the inflammation, if we're able to get rid of that inflammatory stimulus and clean everything up, they're going to hang out a little bit for immune surveillance, just kind of keep an eye on things, make sure we really got rid of the thing and then it's not coming back. So they're one of the last cells to disappear. Again, does not have a classic gross appearance. It has a couple different names. This is all pathology speak. So maybe it'll help you remember it. But non-separative, just tell me it's not us. Mononuclear, as compared to like a polymorphonuclear lymphocyte, which is different, right? So this just means not neutrophils. Inflammation is composed of lymphocytes and plasma cells. There's not a lot of vascular changes. So what I mean by that is it's not juicy, it's not edematous, there aren't a lot of vascular responses. The occurrence, if you see lymphocytes in an inflammatory lesion, it implies that there's some kind of ongoing immune stimulation, because once the immune stimulus is removed, the lymphocytes will undergo apoptosis. So if they're there, it means they're being stimulated. Where do we see this? This is the pretty stereotypical response of surfaces. So your skin, all your mucous membranes, and also the brain. So we see a lot of lymphocytic inflammation, right? It's very common with viral infections, especially that Th1 response, right? So we're trying to get rid of an intracellular pathogen, in case of a virus. We also see it with some intracellular bacteria, but again, a lot of that is going to be macrophage heavy. That's usually their action. And then we also see them quite a bit with immunity to neoplasia, immunity to self-proteins, so autoimmunity. And they're also the predominant cell type in graft rejection, so like graft versus host disease, transplant, stuff like that. Yet, questions? Did you talk about TB all day? I'm always ready to talk about it. Okay, so we finished up yesterday talking about lymphocytic inflammation. It's very frustrating because it doesn't have a gross appearance. It's kind of associated with these things that's where we kind of assume it's going to be. But don't get too worked up about lymphocytic inflammation because you're not really going to see it unless you're looking under a microscope. Grossly, it's often kind of inferred. Granulomatous inflammation, where it's at. So in these two types of inflammation, granulomatous and histiocytic, this is a macrophage predominant inflammation. And because they're macrophages, they don't act alone, they have a bunch of support buddies. So you're always going to also see lymphocytes, blasts, sometimes neutrophils, sometimes eosinophils, depends what's going on. The difference between granulomatous and histiocytic is the difference between Walt and Bruce Banner. A histiocyte is a non-activated macrophage. Granulomatous means that there are activated macrophages, those epithelioid giant cells and the multinucleated cells. That makes sense? So they are both macrophages, but one is quiet, chill macrophages, one is amped up, crazy macrophages, ready to fight. Yes.
Does this mean that they're macrophages, so they haven't been activated, so they're still in circulation?
No, these are in tissue, they're inflammatory.
Okay, so they're already in the tissue, so they specialize in their organ of.
Yep, or they might be resident tissue macrophages, right? It's still histiocytes. So histiocyte is just a non-activated macrophage. So in granulomatous inflammation, you'll often have a nodular arrangement. We're going to talk about that a little bit more. They often have a fibrous capsule. Histiocytic is just sheets of non-activated macrophage. There's no organization, there's no nodules, there's no tubercles, there's no capsule. They're just chilling. But all right, so if you see granulomatous inflammation, what this means for the body is that there has been an acute agent. We have not been able to eliminate it with the acute inflammatory response. So our next strategy is to wall this thing off. Can't remove it, try to wall it off. So again, these are things that the acute inflammatory response is not going to be able to deal with. And that's things like higher bacteria, those bacteria that have complex cell walls, fungus, anything that's intracellular. So for that, remember, we need a cytotoxic T cell response, foreign bodies, anything like that. So anything that the body can't digest or remove or get rid of. This is also the stereotypic response that we see in non-mammals. So the neutrophils, the neutrophil equivalent of non-mammals, so birds, reptiles, amphibians, things like that, fish, their neutrophil equivalents don't have any myeloperoxidase. And myeloperoxidase is what allows pus to be liquid pus. It's what makes pus look like pus. So without that enzyme, you can't form liquid pus, you just form like caseum, basically. So caseous necrosis, granulomatous inflammation is kind of the default type of inflammation in those species. Because the strategy is we're trying to wall something off, it's a good idea to look for the agent in the middle of a granuloma. So a granuloma we're going to talk about is like a jawbreaker, basically. In the middle of this thing is whatever the body is trying to wall off and control. So if you see a structure like this, go right in the middle, see what's in the juicy center. Comes in a couple different flavors. We're going to talk about that shortly. Here is the structure of a granuloma. Remember, this is a macrophage predominant inflammation and it's activated macrophages. So usually in the center, sometimes in the center of these, you will see the thing, the inciting agent, the foreign body, the piece of suture, whatever it is. There's often central necrosis because these structures can get pretty large. They become hypoxic in the middle. And then this necrotic area is surrounded by activated macrophages. Here's the epithelioid macrophages, kind of interlacing like epithelium, multinucleate giant cells. And then on the periphery of this, we're going to have the lymphocytes that are just kind of standing back, directing the inflammation. And then around this whole thing, we're often going to have a fibrous capsule. So we're going to have fibroblasts and collagen and scar tissue encasing this thing to complete the wall. quite beautiful. Here's what that looks like in tissue section. So here are some beautiful granulomas for your eyes to enjoy. This is probably the best one because it has an agent in the middle. Does anybody know what this is? For size reference, these little black dots are lymphocytes, and this is a huge multinucleated giant cell there inside of. It's not a parasite. Anybody know what kind of thing this is? It's pretty big. It's way bigger than a lymphocyte. It's about macrophage size. It's inside of a giant cell. So you see these little soap bubble things?
Oh, is it? Oh.
So it's smaller than a parasite, bigger than a bacteria.
This.
It's fungus. Yeah, these are like fungal spores, basically. This looks like blastomyces. So multinucleated giant cell, all of these guys that are kind of falling apart, these are all the epithelioid cells. There's lymphocytes in the periphery, and this kind of stringy basket weave looking thing is the fibrous capsule. So it's got a little scar around it. This one's lovely because you can really see the necrosis. So vast pink wasteland in the center, that's lymphopactive necrosis, could be caseous. This is microscopic, so we can't tell the difference. Lymphopactive versus caseum is a gross designation. But because this is granulomatous inflammation, I can assume it's probably caseous, active. Because those two are associated. So vast pink wasteland, necrosis in the center. This pink layer, this paler pink, these are all the epithelioid macrophages, the giant cells. They have a lot of cytoplasm, which is why they look pinker on histo. Things that are more densely nuclei, like lymphocytes, are often more blue. So in here, macrophage layer, and then blue layer around the edge is all lymphocytes standing outside directly. The fibrous capsule is in here, but it's kind of hard to see. It's this very brightly eosinophilic stuff, just kind of scattered around the outside. Here's a couple more granulomas. We're in a lung. This could be TB, probably is because they use it all the time. But these are more solid granulomas. There's maybe a little bit of necrosis in the center. These are pretty solid. Again, lots of pink. These are all macrophages. Red with blue, those are lymphocytes, and then they have a scar tissue capsule. Questions about the beautiful, beautiful granuloma? All right, so there are different types or flavors of granulomas. By default, if I say granuloma and I don't tell you a type, this is the one I'm talking about. This one, beautiful, jawbreaker, all of this. If I say just granuloma or granulomatous, assume it's this one. So the default granuloma is a tuberculoid granuloma. Comes from tuberculosis. Sorry. Remember, oid means like, so this is the lesion of tuberculosis, a tuberculoid granuloma. It's the prototype lesion. So what's happening here on an immunologic level, we're getting a strong Th1 cell-mediated response that's causing us to form organized granulomas. So this is literally the definition of a cell-mediated response. When you guys learn about immunopathology, you're going to learn about hypersensitivities. This is technically a type 4 hypersensitivity reaction. It's typified by TB, by your TB skin test you hopefully all had before you came to vet school. So what that is, we're looking for a delayed onset immune response, right? So you inject a little bubble of TB protein under the skin and you wait 2 days, 3 days, right? For your memory cells to say, oh, I've seen that before, or I don't know what that is, I'm not gonna react, right? So that's how we know if you have TB. Have you been sensitized to this antigen before? If I give you the antigen and in 2 or 3 days your body reacts, that means your body has seen it before, right? And it is ready to go. So same thing is happening in the infection, in a tuberculosis infection. Okay, you're getting a cell-mediated response to clear those infected macrophages. You're forming these organized granulomas, lots of necrosis in the center. When you have a really strong Th1 response, that's the ideal for killing intracellular things. So you're usually going to have very few organisms in this kind of granuloma. However, we talked a lot about bystander effect and damage to the host. This is the much more damaging type of inflammation. So these are creating masses, there's a lot of necrosis, there's a lot of tissue destruction. So you're getting less damage from the actual bacteria, but you're getting more host damage from the inflammatory response trying to control bacteria. That makes sense? So we're always on a teeter-totter with inflammation. Here's what it looks like. These are the jawbreakers. These are the classic lumpy lumps. It looks like TB, okay? It also looks like cancer a little bit, right? Especially like this. That, those could for sure be cancer. I can't really tell, except I put it on the slide, so I know they're not cancer. I knew what it was when I put it on here, and I was like, those are granulomas. But grossly very much looks neoplastic because it's multinodular, it's very destructive. Is a fish, we're looking at liver, actually the entire fish is full of granulomas, which is a fish thing, they get a lot of mycobacterium. This is a chicken. This is probably avian TB, Mycobacterium avium. This is a lung from some poor creature that is totally almost effaced by granulomas. This is still multifocal, but there's hardly any normal tissue left between these. This is a lymph node. So here what we're seeing, close, you can see it. So what we're seeing is a lot of caseous necrosis, right? Multiple nodules, there's caseous necrosis, and then you see this like tan white rim around all the little necrotic nodules. What is that? Fibrosis. Yeah, so these are all little areas trying to build a wall. We're gonna make the bug pay for it. I had one person about that. Okay, so this is the default. When you hear granulomatous, think this. There are a couple other flavors. Diffuse granulomatous. So tuberculoid granulomatous means like tuberculosis. This is also called Lymphocytic, which means it's like leprosy, which is also a mycobacterial disease. This is kind of the inverse of TB. So in this one, you have a weak Th1 response and strong Th2 response. Okay, so you have an intracellular bug infecting macrophages, and your body is deciding to respond to that by increasing antibody production. How well is that gonna work? Not gonna work at all. Antibody's not gonna get to the inside, okay? So in this type of inflammation, in Lymphocytic granulomatous inflammation, we're seeing many organisms, because we're doing a terrible job at controlling bug, but damage from antibodies is nothing compared to damage from like a cell-mediated immune response causing necrosis and nodules and massive destruction everywhere, right? So damage from infection and the bug is higher, but host damage from host inflammation is much lower. Does that make sense? So there's always a trade-off between this Th1, Th2 stuff. Yoni's disease is the classic example of this. Yeah.
You say bug?
Bug, the bacteria,
Okay,
the organism, the agent.
it's not actually,
It's mycobacterium.
Okay.
It's a bacteria, higher bacteria.
it's called bugs.
I call things bugs.
Okay.
I was a bacteriologist before I was a veterinarian, so they have a special place in my heart, these bacteria. They all have little personalities. Sorry, bugs are bacteria. Bugs could also be parasites or fungus.
That's what I.
Anything small and infectious is bug. Yeah, sorry. Okay. Good question. Any others? Any other weird language I've used that you don't understand?
I have one more question about the TB test.
Uh-huh.
I've never seen that. So, yeah.
You've never had a TB test before?
Yeah.
We're not.
Yes.
No.
It's required.
Has anyone in this room had a TB test ever? Not. That's not something they're doing anymore?
It's not required.
Oh, cool. How terrifying.
If you work in the medicine.
Make your vaccine.
Is there a vaccine?
Yes, actually.
There is a vaccine, but unless you grew up in a third world country, you did not have it.
So it's not like that.
So what happened? Okay, for this, since nobody's had a TB test, I have to explain how it works. They put a little bubble of TB protein under your skin.
Yeah.
just a little fluid bubble,
Okay. And then they.
like that.
See if that happens.
And then they say, come back in 3 days, and if it looks like this in 3 days, you either have TB or have had TB in the past. If it looks like a normal worm, you don't have TB and never have it. That's the same way we test cattle, the caudal fold test.
Yep.
Same thing. Inject TB protein, come back in 3 days, check for a month.
I was wondering, like, does that, you can only do that test one time if you're like.
No, this does not sensitize you to TB.
Oh, this is just a small amount.
It's a small amount, the body clears it, it's not enough to give you a memory response.
It doesn't.
If you grew up in a third world country, if you were young in a third world country, you have this vaccine. In America, no, it's not a good vaccine, you don't want it, you don't want it.
We also don't want TB.
You also don't want TB, but getting the vaccine as an adult will not keep you from getting TB. And it might make your TB worse if you get it,
Oh, it's okay.
so just don't. We're back here.
Okay, sorry. I thought, so the last time that I had blood work, they were able to test for antibodies. But that's completely different than this.
Are you sure it was antibodies?
No.
There is a blood test for TB, it's called an IGRA, and what they're looking for, they're doing this in a dish. They're taking your white blood cells out, they're feeding them a tiny little bit of TB protein, and if they're like, then you don't have TB. If they're like, oh my god, it's TB, then you've had TB before.
Yeah, when I was working in human medicine, I had to be tested every 3 years.
Every 3 years? That's not very much. When you work with monkeys, you have to be tested every 6 months.
Oh, okay.
This is fun, we're just talking about TB for the rest of the day. Other questions? Yeah.
So I was under the impression that you reacted to a TB test and you didn't necessarily have had TB before, but you had been exposed to TB before, I guess. Okay.
That's a complicated question. That's like a PhD level question.
Like exposed versus.
You either have TB, you've been exposed and had enough to actually develop a memory response, right? So 90% of people who are exposed or infected with TB do not develop clinical signs, they clear the infection and go on to live happy lives. So those people often don't even know they've been infected, right? Because they're just like, oh, I had some mild flu-like symptoms for a couple weeks and that's fine. Right? There are also other things that, so this goes to the sensitivity and the specificity of the test, right? If you have a positive TB test, does that mean you have TB? And is that sensitivity or specificity?
Sensitivity.
If you have a positive TB test. What's the acronym? SPIN. So if it's positive, we can rule it in, is that the case? Well, what else could it be? Other diseases besides TB? There are a couple other mycobacteria that are minimally pathogenic and cross-reactive. That's cool. But it's fairly specific. So now if it's negative, that's a sensitivity question, right? If it's negative, can we rule out that you have TB? It's pretty sensitive, the blood test is slightly more sensitive. The gold standard for diagnosis of TB infection is a sputum culture. Don't go into human medicine, it's disgusting. You have to say things like sputum. Okay, other questions? All right, on to leprosy, which is also, yes,
Sorry, I just want to clarify what you just said. So the
Yeah.
test is sensitive, is specific for TB, but not specific for whether or not you're currently infected.
So,
That's my understanding from what we just conversed, so.
yeah, when we talk about specificity, we're talking about, is it specific for an agent or a disease?
Okay,
So are there other things that can cause a positive test?
Okay.
Right. How good is it at diagnosing disease might be like a predictive value question, which is a different thing, but sort of related, but I know less about that because I haven't had to teach it.
My question regarding scramble.
Yeah, it's okay.
The microscopic image there, like we're saying, it's like sheet factory, and is that sheet plus?
Oh, it's so sheety.
Okay.
It's the sheetiest. Yeah, so let's start with the gross. There's no nodules, but this thing looks thick AF, right? It's like raised and like proliferative. This is ileum, probably. So there's a distal small intestine somewhere. So remember that horse stomach we looked at? That's what your intestine should look like, pretty smooth and shiny. This is very lumpy, bumpy, rough, but it's not nodular, right? It's diffusely thickened. We go under the microscope.
Oh, it's cross.
This is a donut. Yeah, so we've taken, if this is your intestine, we've cut it like this and we've made a little donut. So here's lumen, this is mucosa, this is mega thick for mucosa. That is way too much. And then here's the muscular wall and it looks pretty okay. Here's even closer. So here's the lumen, these are the villi. Here's like the crypts. And your crypts should not look like this. They should be nice and lined up and next to each other. All of this blue stuff in here is macrophages. They're causing a mass effect in the mucosa and the submucosa. Yeah.
So grossly, would you be able to differentiate this type of granuloma with hypertrophy?
Could be challenging. Also, it'd be hyperplasia because this is a mucosa, right? So, yeah, could be very challenging grossly. Other questions about tuberculosis or Crohn's? Okay, so here's the difference in a silly nutshell. Th1, we're making a wall around the agent. It's an organized structure. Low number of agent in the middle, low number of bugs, because we're really good at killing them, but we're causing a lot of host damage. Th2, this is an antibody response. It's not going to work against an intracellular pathogen. Bug is happily proliferating. Okay, it wants to live in macrophages. Inflammation is calling in a bunch of macrophages that are just getting more and more infected. Okay, so the difference between those two makes sense.
Yes.
One is nodules, one looks like hyperplasia. All right, so there are a couple other flavors of granulomas, and they're named just the way we name everything else. We're kind of labeling pieces of words together. So pyo means pus. So a pyogranuloma is a granuloma with a pus pocket in the middle. Delicious. If they're older lesions, the water is going to be resorbed out of that pus and it's going to look like caseum. You can also get an abscess. So an abscess is a neutrophil response that has become chronic and we walled it off. It's not granulomatous, it's a pocket of pus, but it's chronic. So we've put a fibrous capstone on it. So that's an abscess. Those can also look very similar to pyogranulomas. There are some infectious agents that cause this type of inflammation that we associate with classically. FIP, big one, causes of pyogranulomatous vasculitis, so macrophage neutrophils. Anybody diagnosed an eosinophilic granuloma yet? It's cat. You have. Yeah. Oh, sorry. Well, seeing your DBM that you work for. What? Yeah.
PMN. Sorry.
PMN is a polymorphonuclear cell, it's neutrophil. Sorry, and an MO is a macrophage. Okay, eosinophilic granuloma, pretty common in cats. This one on the lip we call a rodent ulcer. Not sure why, no relation to rodents. The eosinophilic granuloma. So it's a granuloma with eosinophils. Parasites often also cause this kind of inflammation. Cats, we often think of it as being part of this immune-mediated weird disease that they get. This is FIP here. It's a kidney with multifocal, looks symbolic pattern lesions. Multifocal raised white to tan. Some of them little sunken centers. Look pretty firm. Alright, how are we on granulomas?
General question about granulomas. So this is like a more chronic kind of inflammation and response to a pathogen. How effective are they at actually clearing the pathogen over a period of time, or is it usually something that never resolved?
It depends. On the thing. Right, like with TB, 90% of people, your immune response is effective in clearing it. In that 10%, we don't know what it is about that 10% of people, so there are some host factors, there's also bug factors. Is this something that, you know, the acute response couldn't deal with and the chronic response can? Or is this something that nobody can deal with and the chronic response is gonna be chronic, right? It's gonna
Yeah.
persist for a long time.
So it's more dependent on what the pathogen is.
It
right?
depends on everything. Yeah, I can't really answer that as a generalization. It depends on anything, you know, has there been treatment, you know, you guys are gonna intervene and treat this. If you're giving an antibiotic in conjunction with the body's inflammatory response, it's gonna have a much better chance of clearing, right? So, depends on everything. Can I answer it? Sorry.
My question is regarding intracellular versus extracellular pathogens. They have big both cause general granulomas, is that true? And then for the tuberculoid and use granulomas, since those are like responses primarily, then are those only intracellular pathogens?
No. We're talking about all granulomatous disease is on this Th1, Th2 spectrum. Pretty much all inflammation, all chronic inflammation is on this Th1, Th2 spectrum, right?
It doesn't really matter if pathogens in cellular issues.
Not really. It more matters, is it something we can deal with or something we can't deal with? Yeah. And there are some subtleties that are like based on the organism. But I'm not gonna expect you guys to remember that next year. Okay, any other questions? Super foundational stuff here, y'all.